afternoon, everybody. So actually, the last two meetings I was talking about orthopedic issues in children with Down syndrome. So this time I thought I'll just talk about problems what we see in adolescents and adults with the Down syndrome. But if you look into the literature, we don't see much information about problems in adults. But I'll just see what all the things I have found out and I'll discuss in detail. All the orthopedic issues happen because of these two problems: hypertonia and generalized ligamentous laxity. So if you have a low muscle tone or generalized ligamentous laxity leading to joint hypermobility, results in the following problems. So this problem happens only when the child starts walking. Before the child starts walking, you don't see any orthopedic issues. So when you put a load on the leg, they can develop hip instability, knee instability, kneecap instability, foot and ankle problem, also cervical spine and spine. And the new condition we have come up is an orthopathy of Down syndrome. This is almost similar to juvenile idiopathic arthritis, but we'll discuss that in detail. So why are we worried about orthopedic issues now? Because the thing is, if you look at about 25 years back, life expectancy of a child with the Down syndrome wasn't that great, only 25 years. But with the latest advent in medical management, especially cardiac problems, endocrine, obesity treatment, the child's life expectancy has improved and the parents' ambition also has improved. So they want a good quality of life for a child as long as they live. So now we see a child with the Down syndrome graduating high school, college, and getting a job and working like anybody else. If you look at the quality of the life of any person, you have to have a good motor function. This is the same with the Down syndrome as well. So for a child with the Down syndrome to integrate into mainstream society and lead a normal life, you have to have a good motor function. But if you look at these predictors of outcome, if a child is less than 11-year-old, we actually look at immobility and tube feeding as poor indicators. Whereas if a child more than 11 years, if a child is an ambulant, the child's life expectancy is going to be good, whatever medical problem the child has. But unfortunately, like if you go and look at the literature, not much available about the natural history about any orthopedic issues, except one or two. Natural history in the sense, if you don't treat a particular problem for about 20-30 years, what is going to happen? We don't have much details. But only thing what we know is, it is going to cause pain and disability at some stage. The only study available in the literature was published in 1993. This is from Boston, USA, in Journal of Bone and Joint Surgery. They have looked at about 65 adults with the Down syndrome. They have followed it up for a number of years. They have come out, about 28% of these adults with the Down syndrome has a hip abnormalities. And they also found out hip abnormality doesn't mean that they have to start from beginning. Even some adults, 20-30 years, normal, started developing hip problem and get into trouble at a later stage. This is a little bit of a difficult table, but I actually took it from the same article. If you look at that, about out of 65 patients, the last line you see, any person you can group into three groups: ambulant, non-ambulant. Non-ambulant or wheelchair bound. Ambulant can be a household ambulator or a community ambulator. If you look at the last line, wheelchair bound and a household ambulators, about 23 out of 65, nearly about 35% of adults by the age of 60 years have become like a household ambulators or wheelchair bound. And if you look at that, those days they lived only mainly up to 40 years. That's why if you look at the numbers, 30 to 39, there were more number of patients with a problem than at a later age. The X-ray shows a 31-year-old adult developing hip dislocation, perfectly normal, without any problem developing a hip dislocation. So what is hip instability? We see this more common in children with Down syndrome, but not as common as a foot problem. Foot problem is one of the commonest problems in the lower limb anomalies. The child doesn't have a problem before they start walking. Usually the milestone is delayed because of the hyperligamentous laxity and a low muscle tone. Sometimes they can have a subluxation, sometimes they can have a frank dislocation. The dislocation can be an acute episode or a habitual dislocation. Once it happens repeatedly, it can happen again and again. Acute dislocation happens in a childhood between 7 and 8 years. There may be a history of trauma, but sometimes there may not be a definite history of trauma. The normally walking child suddenly started limping or not able to put any weight. X-ray will give the diagnosis. You manipulate, reduce it and immobilize, the child will do well. The problem here is, if you look at the ball and the socket is not deep enough for the ball to sit. That is the main problem. That's why once hip dislocates, it will start dislocating again and again. That's called habitual or recurrent dislocation. Here, once it happens again and again. Because the repeated dislocation damages the joint, they end up developing arthritis at an early age. So at this stage, you have to think about reconstructing the hub to cover the ball in the right position so that it doesn't happen again and again. Sometimes, other than a hip dislocation, you can develop a hip dysplasia where the socket is like instead of a cup, it is like a saucer, gradually migrate out. And if that happens, they develop arthritis or a necrosis of the femoral head. This is a case of a 12-year-old with a habitual dislocation. You can see the socket, hypoplastic socket. So you have to cut the bone so much to put the ball back. About 130 degrees, you can see that. Then it starts dislocating again. But unless you do this aggressively in a child like that, they will become a wheelchair bound or a household ambulator when they become big. Next common problem we come across is slip capital femoral epiphysis. Here the ball slips over the neck of the femur. This happens even in normal children, but the incidence in Down syndrome is more than in a normal population. Usually this is due to endocrine causes or obesity. There are two types of slip. So stable slip, unstable slip. Unstable slip is the worst one, where increased incidence of avascular necrosis. That means that the ball can die off because of the poor blood supply. That's what happens in children with the Down syndrome. So whenever we come across a child with a slip epiphysis, you have to fix it to prevent further slip and make sure that it doesn't go in for avascular necrosis. These children won't come to you with a hip pain. Usually the pain will be around the thigh or on the inside of the knee. If a child comes like this, we fix the problem side, we also fix the normal side, because we don't want the same. Suppose something happens to the side, we don't want the normal side to become the same. So we prophylactically pin the normal side also to prevent further damage to the hip. When you move to the knees from hip, the common problem what we come across is the knock knees. You know, the common problems around the knee are knock knees and bow legs. In children with the Down syndrome, in adolescents or in adults, we see more of a knock knees. Okay? Sometimes it's progressive because the thigh is hitting against each other, the knees are rubbing against each other, they'll find it difficult to walk for a long distance. You know, how do you decide when you have to do something, whether to brace or whether you go for a surgery? We measure the distance between the two ankles. If it's more than about 12 centimeters, it's a time we have to do something. If we can pick up a child before the child's growth stops, that is before they are 14 or 15, we can put a simple pin like that to prevent the growth on the inside, so the outside starts growing, the legs become straight. But if you wait for too long, if the child, adolescent become adult, then the bones already fused. If a child comes like that, you have to do an extensive surgery. You have to cut the bone, you have to straighten it. But still we can make the child stand straight, but it needs an extensive surgery. You know, in a child and an adolescent with a Down syndrome, there is increased risk of non-union, infection and other complications. We should try to avoid a major surgery if at all possible. That's why early intervention gives a better result than waiting for a longer time. Sometimes they'll also have a patellofemoral instability, that kneecap moving out or moving out and staying out as it is, or permanently staying in staying out of the knee joint. So we call it subluxation, dislocation but able to reduce, dislocation and staying outside. This is one such a case where you can see both the kneecaps lying on the outside. The one thing about a patellar dislocation is the child will be able to walk, but able to walk with the difficulty. Sometimes they'll have a pain, sometimes they'll have an altered gait. Especially child or adolescent with a dislocation, it's better to put it back in its place so that the gait will be improved and their walking ability will be much better than how it was before. So, if it's only subluxation, we can treat it conservatively with a brace or activity modification. Surgery is indicated if it's completely dislocated. The most commonly studied orthopedic problem in children or an adult with a Down syndrome or foot deformities. The common problem we come across is flat feet. More than 90% of the children and adults will have a flat feet. Okay? The next common is the forefoot problem. The foot problem happens only in the forefoot, not in the back or the midfoot. Sometimes you can see a big gap between the first and second toe. We say it's sandal toe deformity. Then they cannot hold the strap of the sandal, so it will slip and fall frequently. That's why we advise strapping at the back or soft shoes. There are 2 or 3 papers I can quote. This paper was published from the Journal of Down Syndrome Australia. It was published in 2015 recently. If you look at the paper, the cause for the foot pain is 2. One, because of foot deformity. The second, poor fitting footwear. The foot deformity, the common one is of flat feet and the forefoot widening and hallux valgus. That also becomes